Welcome back to Quick Hits, the podcast where we dive into the latest trends and innovations in healthcare technology. In today's episode, we have the pleasure of speaking with Chris O'Connor, the CEO of Yale New Haven Health. Chris possesses a wealth of experience in healthcare leadership, administration, and technology. In fact, Chris's roots in healthcare go even deeper, as he started his career over 30 years ago as an ER technician at St. Raphael's Hospital in New Haven. During our conversation, Chris shares his journey in healthcare, the challenges and trends his health system faces, and the significant role technology, particularly Epic, plays in Yale New Haven's strategic vision. Chris also discusses the impact of the aging population on healthcare services, the adoption of telehealth, and the exciting advancements in AI and research, including work on brain chips and the implications for future medical care. Please enjoy this episode as we uncover expert perspectives on the future of healthcare technology with Chris O'Connor. And don't forget to follow us on your favorite podcasting platform.
And welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you?
Great to be here, Ken.
Well, today we're talking to Chris O'Connor. He's the CEO at Yale New Haven Health. Chris, welcome to the show.
It's great to be here. Thanks, Ken.
Yeah, absolutely. We're really excited to have you on and chat with you for a little bit. We're hoping, first of all, that you can kind of give us a bit of your background. Help us to understand your background in healthcare and technology.
Sure. So I actually started in healthcare 30 years ago as an ER technician at a community hospital in New Haven called St. Raphael's, and that inspired me to pursue an education that would take me into the administrative track, and I've been doing that in hospitals from Baltimore, New Orleans to Connecticut.
And Chris, how long have you been in your role as CEO?
So I took over from, I think, the longest tenured CEO at Yale New Haven, certainly in the recent memory, Marna Borgstrom, who had served in this role for 19 years. And I joined the health system in 2012 as the chief operating officer of Yale New Haven Health. And then about 2 years ago in March, became CEO.
How large is the Yale New Haven Health System?
So we actually are what I would say is mid-size from the national perspective. We're about $7 billion in net patient revenue. We have 5 hospital campuses, but I think that always is a bit misleading because our main academic hub is 1,400 beds here in New Haven. So it's one of the largest hospitals in the country when you look at it from that perspective, number of acute care beds.
So your organization definitely sees your fair share of challenges. I guess just kind of diving into some of the questions, what are some of the significant trends that you're observing in healthcare that particularly a health system like yours are dealing with?
Right now, one of the trends that we struggle with kind of on the daily firefighting perspective is our demand. So particularly in our larger hospitals, we're seeing excessive demand for acute care services. Our emergency departments are backlogged with patient volume, and that creates kind of daily chaos, if you will, that we're accustomed to dealing with, but it doesn't always yield the best patient experience. So we have a great deal of focus on that. How do we improve that? How do we create better throughput, more access, and ensure that the patient experience and the quality of their care ultimately is at the level we expect, which is, the best, frankly.
Chris, following up on that, I actually started my career on the Hill when they passed healthcare reform. And then luckily, a year or two later, I got my first Epic project at Yale New Haven. So I couldn't be more excited to be talking with you today. It just feels like everything's come full circle in so many nice ways. But to that point of coming full circle, during the passage of the ACA, a lot of the issue, or one of the major issues that was trying to be solved, was the overcrowding of the ERs and not enough insured patients. And it seems like the factors now that are causing the overcrowding are different. But given your career, 30 years plus in this industry, I'm wondering how you look at it, this time with, or the increase in demand versus, 12 years ago or prior to the passage of the ACA.
It's a great point, Tyler, that there have been changes to what is leading to the current pressures, but yet you still find yourself in a similar position, hopefully with lessons learned and a little bit better systems to support it. And I think we have, Epic being one of the major components of better system to support the care that our clinicians do every day. But I think that there are a number of factors now that are contributing to the demand push. One is the age of our population. Obviously the gentrification that has taken place of putting more patients. Our aging of our population is probably the biggest contributor. In New Haven, Bridgeport, two areas that we serve, they have socioeconomic challenges that they're poor cities that have limited resources to assist many of our communities. And so that puts more of a burden on the acute care services, so they can't get preventative or more chronic assistance. And therefore they are put in a position that it's only until they get very sick, they then show up at our emergency department. So some of those have changed over time, but some have remained pretty consistent. And the latter one around our health equity challenges, I think, is one that has been consistent over the 30 years. We tend to have, more resources for those who have more assets. And, that's part of the dynamic. I know the ACA obviously did a great deal, certainly in Connecticut, expanded Medicaid and provided greater resources for Medicaid, but Medicaid is inadequate, in my opinion. Certainly here in Connecticut, even though we're one of the wealthiest states in the country, our contribution to Medicaid on a per patient basis is one of the lowest in the country. So, those dynamics persist. They're always a little bit local, depending upon, what's going on in your state or city or community, and you have to adjust to those. But for us, though, that's very much a challenge.
Just to circle back to a couple of things that you mentioned, you talked about your aging population. Now, has that presented a challenge when it comes to introducing things like telehealth? Over the last few years, we've really seen that on the rise to kind of mitigate some of the daily chaos. Is that a challenge for an aging population?
It's remarkable how the generation, and I'll put my mother into that generation, have adapted. I don't think so. I think that, and I think this happened cliff moment over COVID. There was really no alternative. They couldn't come in and get access for an inpatient visit. So their ability to utilize technology and largely, it fell upon likely their children to assist with it. But in many cases, anyway, I know in mine with my mother, but, I think that they've adapted pretty well to the technology. I think as we've started to get in, there's always nuanced challenges, and we build support where we need to. So, when we began our video visits, we would set up a pre-call to ensure, before the first visit, to make sure that the technology was working and that the patients felt comfortable, that camera was, visual too, and working for the clinician. So those are things that we had to add from a resource perspective, but they've done very well, I would say, from an overall assessment.
And Chris, it's really cool to hear these tactics, and you also did talk about Epic a question or two ago, and so related to the technology tactics and usage of systems like Epic, just curious in the bigger picture, what role does technology play in the strategic vision for Yale New Haven Health, and can you highlight any recent innovations that have been particularly impactful?
So, to date myself, I mentioned, in an emergency department in the same community that I'm living in now. And we started there. One of my roles was filling out lab slips when we drew patients' blood and, running them down to the lab. Now we have pneumatic tubes. And if, we ask folks to go on downtime procedures, there's a revolt. So it's changed radically. I mean, even in my, one generation of experience, the reliance on the systems is enormous. And Epic is, probably the one that's most visible. It certainly is the one that we ask our patients to interface with. It's done wonders for being able to convey medical information very quickly. We don't have to, wait on, faxing or, some of the old telephone calls, God forbid, that we formerly used. Now it is instantly available in Epic and available to everybody, which is just a tremendous advantage. That I remember going down to medical records and trying to get old medical records for patients, and hauling up these volumes of folders that were there, and then doctors getting frustrated they couldn't make an evaluation of a medication because they didn't have access to the chart because a resident was going in the back looking at it. So those types of things will never exist again, which is just tremendous. The challenges that it presents is that you become overly reliant on it, and we've put in so many safety features. It's we still need people to think safely and to ensure that there's a thought process behind an execution of work steps. It does create this false sense of automation that we still have a lot of people steps that need to be involved in medical care, and I think it's that's one of the traps potentially of it. But overall, it's been a tremendous advantage. It's costly, though. I think one of the challenges that most industries where you implement efficiencies and technology, there's a decrease in unit cost. I don't know if we've seen that, and so I think that's another challenge that we face. But overall, Epic is kind of the cornerstone for us within our health system. The providers or systems that we bring in have to be integrated or relationshiped with Epic, and it really creates a seamless environment. But clinicians are still struggling with it. I mean, there's still a lot of while it may be efficient for communication, it creates a work burden for our providers. So their in-basket management, which is the tool that you can message your doctor, and believe me, I've read some of the messaging. You could imagine what the spectrum that it holds, from the most technical and sophisticated medical question to what television show should I watch at night? So it goes into the absurd. So that can become a challenge. But we're actually using AI to help support that, and so those are tools that we. It's funny, you have to bring on tools to solution issues that have arisen from technology. So it is a new loop that we are in that I think we're going to be in certainly for the rest of my career.
Well, thank you so much for saying AI. I don't know if Ken and I had a running bet on when AI comes up in each of these conversations. And so I was about to ask you when you started talking about workflow, because some of the projects we've been lucky to work with on Yale have been around the ambient. And then obviously, Epic has an in-basket tool
Yep.
To automate messaging. So while we're at it, let's talk AI. And I know you kind of teased on some of those areas, but I guess maybe more specifically, you mentioned something about unit cost and, the dream of software on the vendor side is you get to zero marginal cost. And it seems on the flip, when do providers actually get to where they're realizing, ROI or maybe not actually paying more for the technology, but the technology is paying them back. And so, yeah, curious to how you see the life cycle and when you think that, or what tools or piece of technology or kind of where we are in the life cycle that that AI maybe will enable true return on investment for all the technology investment you all have done over the past 12 to 15 years.
Yeah, I think there is a return. So I don't want to be so glib to say that, it hasn't reduced. I think the reality is that we can't capture some of the probably most pricey parts of our unit cost, and that's our labor component. And so we don't have perfect time studies that can evaluate a second, a minute, or an hour that is saved on any one of our staff's behalf. And, obviously the value of that goes up the higher the cost for that staff. So if it's a surgeon or a physician versus an orderly or a tech like I was, that value has a range, and the more efficient we can have with all of our inputs into our system, the more efficient we're going to be, and I think the better product we're going to serve the community. So I think that's essential, but we don't do a great job always measuring it. So, what we measure very well are the incremental operating expenses that come with new solutions. And I think you have to take a broad view of how you look at those costs and the impact that it's having on your system. So Epic was a classic example. It was higher priced than its competitors at the time, but we believe the value of both the integrated model of the ambulatory and inpatient modules and the modules that could be added to bring on other functionality was the most integrated that was out there at the time, from our opinion. And the board made a decision for not just the Yale New Haven Health System to deploy universally a single instance of Epic, but also the medical school. And in Yale New Haven's situation, Yale Medicine is a separate corporate entity under the university, but we have an affiliation agreement that's dated back, forever. And we did it together. And so, technology was important, but I would say what was equally or maybe even more important, in my view, substantially more important, was actually the initial decision for Yale Medicine and the Yale New Haven Health System to do it together. Because what that has spawned is a new strategy, which I've adopted since I became CEO, which is alignment with the school. We're doing more and more,
Right.
Far more than Epic, but Epic was a building block to that. So those are things that you can't put a value on, that actually Epic was the instigator for that work, and that was now 15 years ago.
Incredible. It's really I think for technologists like Ken and myself, it's really cool to hear how IT played a part in the strategy and had major benefits. You touched on combination, and that actually reminds me of when I was an analyst at Yale Consulting years ago. There was a presentation that I believe Lisa Stump, CIO, gave around an outlook that many were taking at the time, but is proven to be probably true in a lot of ways, around the consolidation of major healthcare systems. And you did mention early in the program around, as organizations come on board with Yale New Haven, they need to come on board with IT systems and other systems. Curious on your outlook on M&A and how you see the evolving landscape of these provider system combinations, maybe any other insights you have from where you get to sit.
Well, we're actually involved in litigation now with with an agreement that we signed with two hospitals here in Connecticut. And so I won't comment on those, but what I will say is that I believe, at least the experience at Yale New Haven has been, that there is a tremendous value that's driven us being part of a system. One of the areas that I think, again, technology plays a major role in is what we call our care signature, but it's our clinical pathway deployment. And Epic is the cornerstone to do that. We have, over 600 protocols, pathways that have been loaded and are monitored and upkept, on a regular basis with the latest way to treat a patient optimally. And that's all data driven. And we can track now the use and performance of those pathways as they get deployed across our patient population. And right now we're seeing about 45,000 of our patient encounters following those pathways a month.
Wow.
And so, you think of the power of that and the impact on doing it consistently. It actually has impacted our performance. We had, as across our system, so whether you came in Greenwich or at Westerly, Rhode Island, we had some of the lowest mortality rates of COVID because we implemented that pathway system. So I believe firmly in the value of a system. I know that there's lots of reasons that folks want competition. I think competition is incredible, but I think it's very difficult to deploy a technology like Epic as a small independent hospital. And so, access to technology, access to, the thinking, you're just broaden your thought base by the bigger that you are. But I don't think you can get big for bigger's sake. I don't know how much value there is in growth itself.
Right.
But I do think there's value in how you use that growth. It's imperative that we make sure that the value that we're providing to our patients is exceptional, And I understand the concern around, mega hospital systems and the potential impact. And, we've seen examples where they haven't always acted in the, best ways. And so I think there's a need to make sure that that's done effectively and appropriately. But I also believe that we've been able to provide value. From a Yale New Haven Health System perspective, we need to continue to grow just because we want to invest, and we need to ensure that we're committing to things like our research commitment. That, that's a $70 million line item right now that is important to us, that we want to build the discovery for tomorrow. And you can't do that if you're stagnant and contracting.
What do you have kind of in the pipeline when it comes to research initiatives?
So we're actually very fortunate. So this is one where I have a partner, because the dean of the medical school, Nancy Brown, takes the, that's her hat to wear. And what we deploy is the clinical research component of their research portfolio. So they obviously have the basic research sciences at Yale, which are extraordinarily strong and have just had amazing discoveries over time. And then we partner with the School of Medicine to deploy the clinical research component of that discovery model. And we have tremendous things in the pipeline. I mean, obviously, there's a great deal of work going on in oncology and cancer services that I think folks are really excited about. Our neuroscience work, and we just had a discussion around the evolution of the brain chip, and how is that going to affect care going forward. So we've partnered, the Yale School of Medicine partners with the Yale School of Engineering. So I mean, I could go on. I mean, far more time than we would ever have to talk about the excitement that we have in the future for medicine developments with the work that's going on today.
Sure. So, and when you mentioned brain chip, are you talking specifically Neuralink or?
Yes.
Okay.
No. There's more than just Elon's chip out there. So that work that Elon obviously has invested in, that there's a great deal of science going on behind it. It's creating a great deal of excitement that could really impact the delivery of care in neurosciences down the road. So just tremendous optimism about what lies ahead.
Chris, going back to something you said about health equity, and then about getting, or the challenges smaller systems face in implementing Epic. We've also been lucky to work with you all as you rolled out Epic's Community Connect to FQHCs. And then, that's also enabled us to work with more FQHCs, which has really opened my eyes to methods of delivering care to the underserved population.
Yeah, they're essential. I mean, they become one of the key safety nets for, again, chronic care that people need access to. So many of, it's unfortunate, but populations that are disadvantaged have multiple conditions that they're managing and have the least resources to deal with what is a very complex and expensive system. And so the FQHCs play an integral role in each of these communities. They are community-based, so they understand what other community resources are available to support an individual, and have a long-standing relationship with the patient to really manage in a chronic way and in a long-term way their care. As a hospital, we see it only when that episode presents on with an acute presentation. So, they get sick enough that they have to come into a hospital. That's our only relationship with them. So having that connection to our community providers is essential. And it's part of ensuring that we can deliver the best care. I think we had an example of our pathways where, one of our most common conditions, which is alcohol use disorder, which again is more prevalent in those disadvantaged populations, that medication that's prescribed and adhered to post-discharge after an acute event actually is the best. You get the best outcome as a result of that compliance. And it's tough to do. And so by implementing our protocols, we increased the percentage of patients that were discharged on the appropriate medications. And with the FQHCs continuing to monitor, they have a much greater chance of adhering to that medication compliance. So, those facilitators, and Epic as our delivery tool is really essential to ensuring that our patients have get the best care and do it in a way that minimizes the provider's need to communicate in a taxing way. It's right there in the medical record, accessible for everyone to see.
Yeah, no, incredible. And, we talk a lot about empowering patients and providers through the use of technology. So what a strong example too. And also, tying it back to kind of what you've been talking about with some of the benefits of the technology maybe aren't as measurable, but they're clearly there. It sounds like you have the coolest job in the world. You get to touch brain. You're basically doing, the Elon Musk work, but you're also doing, good across the community. You're bringing in this, you're able to bring research at scale, like with the path, the amount of lives you can touch with the pathways. As you have developed in your career, are there individuals or folks that really helped you along the way, or that you were very grateful for, that kind of helped you get where you got? Sorry.
Yeah, I mean, I think everybody, no matter where you are, you have somebody that was, whether it's that second grade teacher, or in my case, I mentioned Marna Borgstrom earlier in the chat, that she was previous CEO of Yale New Haven Health. She was an amazing mentor over the 10 years that we worked together. And I had a little window into it because we were actually negotiating the acquisition of the hospital where I was CEO into Yale New Haven Health. So I saw her on the other side of the table, and then had the privilege to work with her for 10 years. Just an amazing leader, and somebody that I learned a great deal from. But I've had others. I mean, the first COO I mentioned, that was an ER tech at St. Raphael's here in New Haven. The chief operating officer there, Matt Van Branken, was probably my first real mentor, and somebody that I admired and looked up to. And he was incredibly impactful in my career. But there are many. It takes a village to have the benefit and privilege to sit where I sit. And so I could talk about a number of folks that have been instrumental. And of course, there's family that you can't do this without. My wife would put a bullet through my head, I think, if I didn't say that she wasn't impactful in me accomplishing what I've accomplished, because she certainly was as well.
One of the pieces of Yale New Haven I've always admired is the culture. Even 12 years later, since when I first stepped on site at Greenwich Hospital, I still step on site and see so many of the same familiar faces, at least in the IT department. And I would guess it's that way across the system. Curious to your thoughts on building that culture, which I would guess Morna had a very significant impact on, and then how you carry that culture on, and how you think about culture on a day-to-day basis.
Yeah, I mean, obviously culture is critical. And, I think that we've gone through, particularly through the pandemic, some, major speed bumps in our normal journey. And so we're having to adjust to those. But I think building a system that is caring, compassionate, not just for our patients, but for the folks that work here, has been essential. And Marna embodied that. And certainly her 44-year career here at Yale New Haven, I won't even come close to. So for me, it's trying to, carry the torch in a way that thinks about it maybe a little bit differently, because I have a little different perspective, but, embodies the principles that Marna certainly led by. And, that's kind of my guiding light, that, how do you modernize, but continue the incredible success that we've experienced, and do it with different challenges and needs. And so I think that constant formula balance is something that we focus on. And I think the team is essential in ensuring that we have, as many of the factors, understood and managed as it goes forward. And I'm lucky to have a great team around me that, I think we've been relatively successful in doing that.
We We hope today's discussion has sparked your interest and curiosity in the future of healthcare IT. Remember, the conversation doesn't have to end here. You can continue to engage, learn, and discuss by following Health Data Movers on LinkedIn. Your support makes it possible for us to bring these vital conversations to you. If you're looking for the highest quality technology services in healthcare or have questions about today's topics, don't hesitate to reach out at solutions@healthdatamovers.com. Whether you're part of the healthcare industry or simply passionate about the intersection of technology and health, if you enjoyed this episode, please follow QuickHITs on Spotify, Apple Podcast, iHeartRadio, or Amazon Music.